Good morning. When I left Montreal at the Montreal airport, the U.S. Customs and Immigration folks run a very efficient service to check everybody out and make sure that we are safe to come visit here. The customs officer who interviewed me asked me why I was coming, and I explained that I was coming to the Institute of Medicine to talk about elder abuse. And he looks at me and starts asking me some very specific questions. What is elder abuse? Could you define it for me? And I began to wonder whether this was part of a standard customs and immigration screening tool for aliens coming into the country. I was successful at convincing him, and he welcomed me and actually thanked me for the work that he expected this group would be doing, and so I'm conveying that to all of you on behalf of the customs officer. Couple of acknowledgements. My funding for my research has come from the Canadian Institutes of Health Research, the Human Resources and Social Development Canada, and the Public Health Agency of Canada. And I guess my major conflict of interest is that I was the principal investigator on one of the tools that was just mentioned, the EASY. And so comments that I will make about the EASY, both some strengths and weaknesses, are obviously subject to bias. The other disclosure that I would make is that for the last 20 plus years, I have been a family caregiver. Both of my parents suffered from Parkinson's disease. My wife's mother died of progressive supranuclear palsy. My sister's in-laws both died from neurodegenerative diseases, and my wife has a neurodegenerative disease. And so I'm very familiar with what it's like to be a caregiver, and so I'm talking not only as a researcher, but as a caregiver who, over these period of time, has been instrumental in firing 3 paid caregivers, 2 for verbal and emotional abuse, and 1 for physical abuse. So I talk from experience. Look at a few definitions of approach to detection. I think these are common to all of us, but let's just make sure we are on the same wavelength because it has implications for how we look at the tool. Screening is the detection of an entity within a population that does not have signs or symptoms or has undetected signs or symptoms. By contrast, case finding is screening for those who have risk factors for an entity or whose presentation is suspicious for that entity. What happens in family practice? In family practice, we kind of get mixed up a little bit between case finding and screening. And as I tell our trainees, the approach that a family doctor should take should not be evidence-based, but should be evidence-informed and patient-centered. So that whatever we do, we're focusing on the patient based on the literature, but we're not slaves to that literature. In order not to be a slave to the literature, and in order to understand whether a doctor is doing case finding or screening, I put up a decision-making model, one of the earlier decision-making models that some Australian family physician colleagues developed in the late 1970s. And what it effectively does is show that when doctors, family physicians, make diagnoses, make decisions, it is rarely a linear process. The moment that somebody walks in the door and we look at them, we are already excluding and including certain criteria. The moment we see them walking down the corridor in one way or another, the moment we see how they are dressed, whether they are smiling or not smiling, we make certain decisions, exclusions, inclusions. And so if you ask an average family physician, are you screening or are you case finding, in many cases they will not know. That's going to be important because we use that to make our decision as to what kind of a tool we would look for. We, meaning family physicians. Family physicians are well positioned to detect elder abuse. Family physicians may be the only people outside of family who regularly see seniors. There is some U.S. data that suggests that it's up to 5 times a year because of the increased chronicity that seniors have, and with the increased longevity, there are more visits to doctors. As well, if you have an established doctor-patient relationship, the likelihood is that that relationship is going to promote trust, and trust, in theory, is to help promote disclosure. In the doctor-patient encounter, most patients are accustomed to doctors asking direct questions about sensitive topics. That makes the situation very different from somebody who calls on a telephone, or from a social worker who walks in the door who's never seen the patient for the first time, or from a nurse who does triage in the emergency room. As well, our physical exam gives us opportunity to look at abnormal lab findings and unexplained deterioration that may help us to be suspicious for elder abuse. Mark Lax, a number of years ago, indicated that physicians rank 10th amongst health professionals and paraprofessionals in actually detecting abuse, and that physician reporting accounts only for about 2% of elder abuse occurrences. Now, admittedly, those data are old data. I haven't seen much in the way of new data, but I don't think it's much better. What are the barriers for family physicians to detect elder abuse? The first is just the lack of awareness about elder abuse as an issue to look for. The second is, as already been mentioned numerous times, physicians lack awareness that elder abuse, independent of the act of abuse, carries high mortality rate, Mark Lax's work, and a lack of knowledge about how to identify elder abuse. Another problem in the past has been the absence of screening or detection tools. The ones that existed were too long for office use by doctors. They used words and vocabulary that doctors were not comfortable with. Some were designed for home assessment, and as somebody commented yesterday, unfortunately, doctors are making fewer home visits than we would like to see. And some of the screening tools that have existed in the past involve interviewing caregivers who themselves may be the abusers. Doctors are human, and they may fear of offending patients, and there may be victim reluctance to report to the doctors. Patients present ethical and confidentiality issues. Yes, my son is taking my money, but I don't want you telling anybody about it. It's my business, and I reserve the right not to disclose. Another barrier is the doctor belief that detection won't lead to a solution, and that's a lot of what this whole gathering has been about, looking to find solutions. And finally, the issue of ageism, misinterpretation of signs and symptoms. Even those who commonly work with the elderly have a bias. In our own research that led to the development of the EASY tool, we brought together 40 experts in the province of Quebec, either physicians, social workers, or nurses, who either had a specific interest in elder abuse or specific interest in care of the elderly. And we asked them in a series of focus groups to consider various aspects of what elder abuse might look like. There was almost no way we could dissuade this group from listening to our instructions that said, please consider anybody over the age of 65. Their focus was on the frail, weak elderly. These are the people who were our leaders in the field. They were propagating, at least within our focus groups, the ageism that we're all trying to avoid. Another area of potential abuse, and this is perhaps a little bit controversial, is the legal issue. Within the United States, there is a reputable web-based resource for doctors that has some 400 plus topics that doctors can access. And yet when a doctor goes to find that information on the website and plugs in elder abuse, you will not get an answer. What you will have to do is search under legal and ethical issues. It will not be found under geriatrics, elder care, or aging. There is a bias that I think defeats the purpose of physicians looking. Physicians get frightened about legal issues. They don't want to get involved in legal issues, yet here is a major organization putting elder abuse where it should not be. The issue of mandatory reporting has been addressed. In Canada, only 3 of our provinces have mandatory reporting. The others do not have it, ostensibly because elder abuse issues are covered by the Canadian Charter of Rights and Freedoms. But the feedback that we have received from physicians is, at least in Canada, they don't want this to be mandatory reporting. It takes away the opportunity to explore questions in a deeper way without patients feeling that things are going to be revealed against their will. Physicians have barriers as well because of confusing guidelines. The American Medical Association in '92 recommended screening for family violence. The Canadian Task Force on Periodic Health Exam in '93 said there was insufficient evidence for or against elder abuse screening. Here in the US, your task force 3 times has said the same thing as the Canadian task force, and the UK 2002 said health professional screening increases likelihood of detection, but may not result in improved outcomes. Well, hopefully we'll change that. Conditions necessary for detecting elder abuse. When we went to the literature, we found 3. One of them was an awareness of what elder abuse is, plus a high suspicion, a high index suspicion. The second thing we found was that American geriatricians commonly problem solve on high index of suspicion. And finally, a strong predictor of doctors seeing and reporting elder abuse is being able to ask direct questions. And I'll repeat that up until that point, there were very few tools that asked direct questions. This led us to work on the Elder Abuse Suspicion Index, or EASY. Our expectations were it could be administered by a family physician in an office setting. It would be useful both in a case finding or screening situation to generate enough suspicion to justify referral to a community expert, to APS folks. Therefore, it was not necessarily designed to generate psychometric properties necessarily consistent with what would be considered an outstanding screening tool. We expected it could be used on those over the age of 65 with a Folstein Mini-Mental score of at least 24. That criterion of 24 was not established by us in terms of competency of the individuals. It was established solely as criterion of research ethics committees, and we know that scores less than 26 include mild cognitive impairment, so the tool can be used with patients with mild cognitive impairment. We have validated the tool in English and French, and it can be used over time to desensitize people to discussing issues of elder abuse. I don't have time to go into what the tool involves, but there is a single question that looks at dependency, a second question on neglect, a third on psychological and emotional abuse, a fourth on financial and material abuse, fifthly on physical and sexual, and a sixth an observational question by the health professional who's asking the questions. How did the doctors in our study react to the tool? We had 885 patients in our validation study, 104 doctors, 68% response rate. Terrific response rate. I just sat on my colleagues and made sure they answered the questions. 96% said that the tool was somewhat to very easy to use. 2/3 said it took them 2 minutes or less. 97% felt that it would have some to big impact on their practice. 2/3 said it made them far more aware of what elder abuse was about and more confident of what to look at. And 81% thought it would have somewhat practical use in the office. We've moved beyond the EASY to a self-administered version of the EASY called the EASY SA. The EASY SA simply represents questions 1 to 5 of the EASY. We removed the 6th question, which is the observational question, and we have found that the EASY in self-administered form is feasible and acceptable in words and in content for seniors to self-administer in the format that we have listed on the slide, that is the font size and so forth. We have created a website for the EASY, which gives a background description of how it can be used. And courtesy of colleagues internationally, there are now versions of the EASY in English, French, Spanish, Italian, Hebrew, German, Japanese, Portuguese, and one of our colleagues here has expressed interest in working on it in Chinese, and I'm very grateful for that. There are hyperlinks available to obtain pocket card versions or digital versions. This is what the pocket card looks like on the front. It was created as a project of the Public Health Agency of Canada, our research group, and the National Initiative for Care of the Elderly in Canada. And we have distributed this pocket card to 24,000 family doctors across the country. The inside the pocket card looks like this. There are the 6 questions in a yes or no format and a listing of 2 or 3 phone numbers in each Canadian province where either patients or doctors or other health professionals could call for help. Is there any harm to the seniors using it? The seniors reported no difficulty, and your most recent U.S. task force has indicated that screening for intimate partner violence does not seem to do harm to vulnerable patients. To end off, I'll briefly say what the unknowns are. The unknowns for the doctors, we delivered them to 24,000 Canadian family doctors. We don't know yet what the uptake is by the doctors. We don't know how they're using it, whether it's in screening or case-finding format. There is an initiative by the National Initiative for Care of the Elderly to do this follow-up, and we hope that we'll get some data on it. My belief is that the only way to get doctors to do it is to pay them, and I don't think it's going to take much to pay them to do this. Unknowns for nurses. Janice Dumont in the University of Toronto and myself and other colleagues had a grant proposal to study its use with nurses. Unfortunately, we didn't get funded. We're going to go after that again, go after the money again. Here in the States, there was an attempt in a large Midwest urban setting for a nurse to do a study in a community practice, but the corporation that ran the practice did not have interest in it. And in Ireland, Amanda Phelan has a project going throughout the country trying to use the EASY tool through the emergency rooms. In Spain, the EASY has been validated and is used by social workers. They get sensitivity ratings of 51% and specificity of 95%. Finally, in very raw data, this is material that I've just received from a group of nursing homes in the province of Alberta. There are 179 nursing homes that use the electronic health record. In the period of January 12 to March 2013, they used in fairly unstructured way the EASY on all new admissions, and we report the positives for the various forms of neglect. I don't think it's relevant to do an analysis of it because I don't know the nature of the patients or the nature of the nursing homes, but suffice it to say there are places that are trying it out. When we started our work, we said that our motto would be EASY does it. Well, EASY does do it, but we think more research is needed. Thank you.